that is the drugs modifying autonomic nervous system, of which the first part is the drugs acting on the adrenergic nervous system. I hope you all remember, you are well equipped with the knowledge of first year or first prof. That is how the mechanism of neurotransmission and what are the steps and how they act post-synaptically and how they are being terminated, and what are the different types of receptors involved in the different systems like sympathetic and parasympathetic nervous system. And over and above, you must know what is the difference between what are the different parts of the nervous system, what is the difference between the autonomic nervous system and the somatic nervous system. I think I did not repeat those because the time is very short. So I am straight away going to our topic, that is the adrenergic system. Now, in this course, there must be some recapitulation of that is the neurohormonal transmission. These are the competencies that will be covered in the coming sessions. That is the describe mechanism, action, types, doses, side effects, indications and contraindications of adrenergic drugs. Not in one lecture, it may be followed by another one or two more lectures. These are the SLO. You write down this. What you have to read in this adrenergic nervous system. You just copy this. So it will help you to later on when you are going to revise the topic before examination. So steps of transmission, name the different drugs, that is the classification and responses, types of receptor and responses of stimulation of different adrenergic receptors. What are the different drugs present in the adrenergic nervous system? Actions, uses, side effects of adrenaline mostly. Mention the characteristic features and important uses of other adrenergic drugs. So you can well understand that adrenaline is the prototype drug of this group. What do you mean by prototype drug? What do you mean by prototype drug? If you can remember the first class which was taken by me, in one group there are so many drugs are available. It is not possible for us to read each and every aspect of different drugs of that group. So from that group, usually the first drug which has got immense various effects of that on that system will be considered as the prototype drug. Such as here in adrenergic or sympathomimetic drug, adrenaline is considered as the prototype drug. So what are the functions of NS? It is the recapitulation of your previous class. It is well evident when you are placed in a very cold and chilly atmosphere suddenly. What will happen? There will be vasoconstriction. It is not our voluntary control. When there is massive loss of blood or acute hypoxia, if there is massive loss of blood, how the body will try to compensate that? Because again the vasoconstriction. But when there is hypoxia, there is vasodilatation. So all these are autonomic functions which is not under our control. And lastly, if you are to flight or fight, this is the functions of the sympathetic nervous system, flight or fight. But during rest, some autonomic functions are going on, and that is done by the parasympathetic nervous system. Now, during the transmission of nerve impulse across the synaptic cleft, there are presence of certain substance is very essential because there is no continuity between the presynaptic nerve and the postsynaptic nerve. There is a gap. How the impulse is being transmitted to the postsynaptic receptor? It is by the help of releasing certain substances. Those are known as the neurotransmitters. What are the features of neurotransmitter? How can you tell that this substance, that acetylcholine, is the neurotransmitter of the parasympathetic nervous system? Noradrenaline or adrenaline is the neurotransmitter of the sympathetic nervous system. How will you tell what are the features, characteristic features? They should be synthesized in the presynaptic nerve. They should be stored in the vesicle, and when there is impulse coming on, that will be released by exocytosis into the cleft to act on the postsynaptic receptor, and immediately after the action is being terminated, should be terminated. So these are the criteria for a neurotransmitter. There are certain other terms it may be asked in the oral or theory. What do you mean by neuromodulator? It is present in the, again in the neuron, also in the axon. But what is the difference? It does not have their capacity to stimulate a receptor, but they can modulate the presynaptic or postsynaptic responses. They have got no action like the neurotransmitter to activate any receptor, but they can modulate the responses that may occur either in the presynaptic or postsynaptic region. These are known as the neuromodulator. The response may be stimulated or inhibited. Example, can you cite an example? Can you cite any example? Just one example, nitric oxide. Another term is the neuromediators. Can you mention any example of neuromediator? That is when the receptors are being stimulated by the neurotransmitter, how the actions is being reflected, not by its own. There is some changes in the receptor that will lead to formation of second messenger, which helps in eliciting different types of action. Those are known as the neuromediators. Example, there are so many examples, IP3, DAG, cyclic AMP. So these are the neuromediators. And what are neurohormones? They are synthesized at one site and they are poured into the vascular system to go to the distant organ, and they act on that distant organ. So those are neurohormones, that is the hypophyseal hormones. So it is very important to know what are neurotransmitter, what are neuromodulator, what are neuromediators, and what are neurohormones. Now, what are the neurotransmitters of the ANS? Mainly acetylcholine and norepinephrine, and also dopamine. It is in the dopamine for only the central nervous system. Now, where you can find the acetylcholine to act as a neurotransmitter? To act as a neurotransmitter, all the preganglionic nerve ending, be it sympathetic or parasympathetic, preganglionic nerve ending. You can see that here. So, and all the postganglionic parasympathetic nerve ending in the parasympathetic nervous system, where acetylcholine is the neurotransmitter. But postganglionic sympathetic nerve ending, where acetylcholine may act as a neurotransmitter, can you give any example? Supplying the sweat gland and also in the adrenal medulla. Now, norepinephrine, what are the sites? It is the postganglionic sympathetic nerve ending, excepting those supplying the sweat gland. You can see here the postganglionic sympathetic nerve ending, acetylcholine is the neurotransmitter, and also in the adrenal medulla. So now we can, you all know these. What are the steps? Number one, axonal conduction or impulse conduction through the axon, release of neurotransmitter. Release of neurotransmitter. After release, there is action on the postsynaptic. এগুলো লিখতে হবে না, এগুলো তোমরা জানোই, এগুলো লিখতে হবে না, just recapitulation. Postsynaptic activity and termination of action. So these are the steps of neurotransmission. What are the receptors? Receptors may be presynaptic receptor or postsynaptic receptor. So there may be receptor in this region or in this region. So these are the presynaptic receptor and these are the postsynaptic receptor. Presynaptic receptors are mainly involved in auto-regulation of release of different types of neurotransmitter of a particular system. And these presynaptic receptors may be termed either as autoreceptor or heteroreceptor. Autoreceptor means, suppose we have one example of sympathetic nerve ending. Here is presence of alpha 2 receptor. Now, after release, this can stimulate this. What is the action? It will inhibit the release of norepinephrine. So this is known as the autoreceptor. Similarly, in case of parasympathetic nervous system, acetylcholine may stimulate M2 receptor, and there will be inhibition of acetylcholine release. So these are termed as autoreceptor. That means those which can influence the release of their neurotransmitter. Alpha 2 receptor, adrenergic receptor, it will inhibit the release of norepinephrine, that is the sympathetic neurotransmitter. That's why it is known as the autoreceptor. And what are heteroreceptor? Suppose this is sympathetic nervous ending. In some system or region, there is some close proximity of the parasympathetic nerve ending. So there may be M2 receptors are situated, and that M2 receptor can inhibit the release of norepinephrine. So this M2 receptor acts here as a heteroreceptor because it can influence the release of other neurotransmitter like the sympathetic neurotransmitter. That's why this is known as the heteroreceptor. So these are how there is autoregulation occurs and what are the different types of neurotransmitter. After that, there is also presence of postsynaptic receptor to have effect on their own system. Now we can see here the same thing. You can see here this is the parasympathetic nerve ending, and here you can then close proximity of the sympathetic nerve ending. There is release of norepinephrine that can stimulate the alpha 2 receptor, which inhibit the release of acetylcholine. So this alpha 2 receptor will act as a heteroreceptor. Here you can see that acetylcholine autoreceptor inhibits its own release, but whereas alpha 2 receptor will inhibit the release of parasympathetic neurotransmitter. So this is heteroreceptor and this is the autoreceptor. Adrenergic neurotransmitters, as I told you, these are the adrenergic neurotransmitters. How there is synthesis and release of norepinephrine. What is the mother substance? It is the tyrosine. Where from it comes? এটা কোথা থেকে আসে টাইরোসিনটা? Phenylalanine, which is the dietary product. By the enzymatic action, it is transformed into tyrosine. That tyrosine actively transported into the cytoplasm, where it will acted upon by this tyrosine hydroxylase, and there is formation of dihydroxyphenylalanine, that is the DOPA. And this is known as the rate limiting step of the synthesis of norepinephrine, and it can be inhibited by one substance, that is the metyrosine, this rate limiting step. After that, there is formation of dopamine. Why? Dopamine beta hydroxylase. So there is formation of dopamine. That dopamine, with the help of this vascular membrane amine transporter, it will be packed into the vesicle. Packed into the vesicle where it is transformed into norepinephrine, and it is present along with other substance, that is the ATP, substance P, like this. When there is impulse conduction, action potential comes in. As a result, when there is this vesicle will be attached with this membrane, presynaptic nerve terminal membrane. There is certain proteins are being responsible for their attachment, that is the vesicular amine membrane proteins. Various types of proteins are there. And at this time there is entry of calcium ion. That calcium ion will cause exocytosis of this vesicle, and there is release of this content of this vesicle, norepinephrine, ATP, and substance P. Substance P. Next, there is action of this norepinephrine or fate of this released norepinephrine. It mainly acts on these receptors, that is the adrenergic, different types of adrenergic receptors, and produces this action. After that, what is the criteria of the neurotransmitter? Immediately after producing action, their action should be terminated. How it will be terminated? Most important is the reuptake, that is the uptake 1 by the norepinephrine transporter into the cytoplasm, presynaptic nerve terminal, and that may be inhibited by certain substances, that is the cocaine. Cocaine, it is not used clinically, but the other agent is the tricyclic antidepressant, a very important class of drugs in the use of various types of depression. So that this uptake 1 can be inhibited by these drugs. If there is inhibition of this uptake 1, what will happen? There is residence time of norepinephrine in this cleft will be much more, and they can act on these receptors for prolonged period. So that is one. Number 2, by diffusion to the surrounding tissue. By diffusion to the surrounding tissue, and here another, that is the which is known as the uptake 2. So that is how the action of norepinephrine is mainly terminated here. But when you give adrenaline or norepinephrine from outside, that is the exogenously administered norepinephrine, how their actions will be terminated? There is no question of this reuptake or uptake 1 or uptake 2. Here comes the role of different types of enzyme. What are those enzymes? 2 enzymes are very important. One is the MAO, monoamine oxidase, and another is the catechol O-methyl transferase, that is the COMT. Now, this MAO may be present here also, the small amount. So the norepinephrine entered here, that may be deactivated by the MAO enzyme present here. But the exogenously administered norepinephrine will be metabolized mainly by COMT. It is present mainly in the liver and plasma. Now here you can see these are the different enzymes. Now you can see what are the sites where the drugs might act. একটা তোমাদের বললাম এখানটায় reuptake, that can be inhibited by this. There is this axonal conduction. It may be affected not by drugs but by certain toxins. Can you remember the name of those toxins? Tetrodotoxin, saxitoxin. They can inhibit the entry of sodium. Various types of shellfish and other toxin. They can produce this tetrodotoxin or saxitoxin. And some species, that is some frogs, they can produce another toxin. What is that toxin? Batrachotoxin, B-A-T-R-A-C-H-O, batrachotoxin. It can produce spastic paralysis. How? It can stimulate the entry of sodium. So that does not cause the paralysis, flaccid type. There will be persistent depolarization. Ultimately, there will be paralysis. So these are the three types of different toxins which can modulate the axonal conduction. Another side is here. There is a transport of dopamine into this vesicle that can be inhibited by one drug, very important drug at one time for the treatment of hypertension, and that is the reserpine. They can inhibit this transport, thereby they deplete the norepinephrine. Ultimately, there will be no norepinephrine will be available here to act. So there will be hypotensive effect. So that is another site of action of drugs. So these are you can see here, these are drugs which was used for the treatment of hypertension. Now it is not used. Just for how the system may be deactivated. That is another example. This can be inhibited by these two drugs, bretylium and guanethidine. That is the exocytosis can be inhibited by these two drugs, bretylium and guanethidine. And lastly, various types of blockers, receptor blockers, they may act here to block the action of norepinephrine. So these are the steps of synthesis as well as the site of actions of different drugs in the various steps of synthesis and termination. Another I did not tell here, that is the various types of enzyme inhibitor, that is a MAO inhibitor or COMT inhibitors. They can also affect the action of this norepinephrine. And you can see here, these are the steps. These are the steps, that is the tyrosine transformed into the dopa by tyrosine hydroxylase. You can see here there is one hydroxyl group at 4 position, and there is addition of another hydroxyl group at 3 position. So that will dopa. Now we can see here there will be beta hydroxylase, that is the alpha position, and this is the beta position. You can see here that is addition of hydroxyl group here. So that will lead to, I just forget one thing, that is here. In beta position hydroxyl group, there is formation of norepinephrine, and here it is decarboxylation, that is the dopa decarboxylase enzyme will act here. Dopa decarboxylase enzyme will act here, and this carboxyl group will be abolished to form dopamine, and there is formation of norepinephrine, that is from dopamine you can see that beta hydroxylase enzyme, and there is formation of epinephrine. Why it is formed? Now, from norepinephrine, the formation of epinephrine, what is the site? Is it in the sympathetic nerve ending? There is the formation of epinephrine from norepinephrine. Where it is? This transformation will occur. কোথায় হয়? সে কি? Who was the first boy in physiology? Who is the first boy in physiology or girl? কে ফিজিওলজিতে অনার্স পেয়েছো? দাঁড়াও দেখি, কে আসেনি? সেকেন্ড হাইস্ট কে? তুমি? কে সেকেন্ড হাইস্ট কে? যাও, ধারে কাছে না থাকলে পরে যখন পাস করে এসছো, you should know this, where epinephrine is being formed in our body. It is not in the sympathetic nerve ending, adrenal, medulla. তাহলে বলছো না কেন তখন? ভয় পাচ্ছিলে? না ভয় পাচ্ছিলে? So the site is in the adrenal medulla. There is formation of epinephrine from the norepinephrine. Now I have already covered this. That is the pre-junctional control. Norepinephrine release is controlled by autoreceptor. Autoreceptor release is inhibited by alpha adrenergic receptor. Release may be stimulated by beta adrenergic receptor. These are the autoreceptor, whereas it can be inhibited by heteroreceptor like the M2 parasympathetic receptor. Termination action I have already told. Now, this is how the process of metabolism. You can see here, that is, what is this? Norepinephrine. Norepinephrine with the help of MAO, formation of dope gall. It is the epinephrine that is formation of dope gall. What is dope gall? What is the full form of dope gall? Dihydroxy phenyl glycoaldehyde. Gal means aldehyde. And with the help of these two enzymes, reductase and dehydrogenase, there is formation of dopeg. What is dopeg? 3,4-dihydroxy phenyl ethylene glycol. And there is formation of DOMA. It is again 3,4-dihydroxy mandelic acid. Dihydroxy mandelic acid. From here, there is here it is formation of with the help of COMT normetanephrine, and here is the metanephrine. What is the next step? You can see here with the help of this COMT there is formation of MOPEG, 3-methoxy-4-hydroxy phenyl ethylene glycol. From here there is formation of MOPGAL, monohydroxy phenyl ethylene glycoaldehyde, and here there is formation of ultimate product is the vanillyl mandelic acid. What is the importance of knowing this? That is the VMA. Why we should know the VMA? Kano? If there is high level of VMA, what will be your inference or impression? Non-epinephrine synthesis will be much more. Non-epinephrine or epinephrine, be it, the synthesis will be much more. কখন হয় এটা? Obviously, tumor, that is a pheochromocytoma, tumor of the adrenal gland, pheochromocytoma. It can be known when there is pheochromocytoma, there is increased release of adrenaline, and the ultimate end product, that is the VMA, will be increased. VMA will be increased. So that is one example why you should know this, the different metabolism steps of norepinephrine. Difference between, there are two types of enzyme MAO isoform, that is the MAO A and MAO B. Main difference is the location. It is in the nerve ending and liver, kidney and brain. But you never find COMT in the sympathetic nerve ending. It is only in the liver and kidney. It is the COMT. Isoform, there are two isoforms are available, MAO, that is the MAO A and MAO B, whereas there is no isoform, there is only one isoform, that is COMT. Selective inhibitor, you have got selective inhibitors for this, also for this. And MAO A, that is a moclobemide. It is a reversible MAO A inhibitor, moclobemide, whereas MAO B specific inhibitor is the selagelin and rasagelin. And here we have got two drugs, that is the entacapone and tolcapone, which can be used in Parkinson's disease, and these drugs may be used both in Parkinson's disease as well as in depression. Effect of tyramine after enzyme inhibition. Tyramine, it is the end product from the dietary in the intestine. Tyramine is being formed. This tyramine will act as an indirectly acting sympathomimetic agent. It will increase the release of non-epinephrine from the nerve ending. It will increase the release of norepinephrine from the nerve ending. As I told you, if you can remember that picture, the reuptake was done with the help of norepinephrine transporter. But the tyramine has got more affinity for this transporter. So, in place of norepinephrine, amphetamine is being taken up by the nerve terminal. And when it enters into the cell, this enzyme, the transporter will be freed, and that transporter will carry the norepinephrine from the cytoplasm into the synaptic cleft. So, there will be extensive release of norepinephrine in the synaptic cleft. So, if the patient is hypertensive, there will be alarming rise of hypertension. There may be hypertension crisis like this that may occur. That is known as the cheese reaction. Short note. Cheese reaction, short note. So, that is the mechanism why there will be hypertension with this. Now, when we can see that, it is usually seen with the non-specific MAO inhibitors, that is the phenelgin, tranylcypromine, isocarboxazide. These are the non-specific MAO-A inhibitor. So, it is usually seen with these drugs, and that is because MAO-B enzyme is present mainly in the basal ganglia. MAO-B enzyme is present mainly in the basal ganglia. MAO-A is present in the synaptic cleft, presynaptic nerve terminal. That is why stimulation of MAO, inhibition of MAO-A enzyme will lead to excessive release of norepinephrine. But if we can give reversible MAO inhibitor, the incidence of this cheese reaction will be much less. That is, if we use moclobemide, that will be much less. And if we can use specific MAO-B inhibitor, there will be no chance of development of cheese reaction. Okay. So, if it comes as a short note, all you have to mention. Sometimes you will be asked, what are catecholamines? What are catecholamines? That is the benzene ring with 3,4 addition of 3,4 position hydroxyl group. That is known as the catecholamine. You can see that is the benzene ring. That is the benzene ring, and it is the side chain, addition of side chain. You can see here there is addition of 2 hydroxyl group at 3,4 position, and that is known as the catecholamine. So, there are various types of catecholamine in our body. Endogenous catecholamine, usually epinephrine, norepinephrine, and also dopamine. Epinephrine, norepinephrine, and also dopamine. And exogenously, there are various types of drugs available. Isoprenaline, not used, not very useful nowadays, but the other drugs, that is the dobutamine, dopexamine, and phenoldrama, they are the catecholamines. There are certain beta-2 agonists which are also catecholamines. Now, why should I know whether the drug is catecholamine or not? If a drug is catecholamine, that cannot be administered through oral route. It will be inactivated in the stomach. That is the importance of knowing whether the drug is catecholamine or not. Receptors. Now, coming to the different types of adrenergic receptors, these are alpha and beta. Alpha again divided into two, alpha 1 and alpha 2. What are the main sites? In alpha 1, the main site is the vascular cell. That is the smooth muscle, that is the vascular. What is the action? Strong vasoconstriction. Strong vasoconstriction. Other is the non-vascular region. Important is the genitourinary. It is also, you have to know, genitourinary. With the help of this alpha action, there is contraction of the trigone of the bladder as well as contraction of the sphincter. What will happen? There will be retention or obstruction to the outflow of the urine. It is useful to know the treatment of benign hypertrophy of prostate gland. That means if we use alpha blocker, alpha 1 blocker, the complications or the symptoms of BHP will be relieved. তাই তো? তাহলে কি হবে? ট্রাইগন রিল্যাক্স হবে, স্ফিংক্টারটাও রিল্যাক্স হবে, আর ইউরিন ফ্লো আবার restored হবে. So that is one important thing. Now intestine is usually the relaxation with the alpha 1. Liver, it is another important site. You can see that glycogenolysis and gluconeogenesis, very important, because administration of adrenaline or epinephrine may lead to rise in blood glucose level. What is the mechanism? One mechanism is the glycogenolysis and gluconeogenesis. And I already mentioned the prostate gland. Now this alpha 1 receptor may be of 3 types: 1A, 1B and 1D. 1B present in the vascular system. So to be effective, if we give alpha 1 blocker, there will be strong vasodilatation, right? Which is not desirable because there will be fall in blood pressure. Usually the orthostatic hypotension will be much more. তার মানে কি, পেশেন্ট যদি বসে থাকে বা শুয়ে থাকে, উঠলো, মাথা ঘুরে পড়ে গেল। হ্যাঁ, তাহলে আমরা কি চাই? স্পেসিফিক 1A আর 1D হচ্ছে প্রস্টেটে থাকে। So the drugs which has got blockade effect on 1A and 1D, sparing the 1B alpha receptor, that will be more effective in benign hypertrophy of prostate, because there will be less chance of development of orthostatic hypertension, which is usually mediated through alpha 1B. ঠিক আছে? Next, alpha 2. It is the pancreatic beta cell decrease insulin secretion. Again, the rise of blood sugar level may occur. Platelet aggregation, alpha 2 receptor, and another most important is the presynaptic nerve terminal decrease the release of norepinephrine. Decrease the release of norepinephrine. Now coming to the beta 1, beta receptor. It may be divided into beta 1, beta 2 and beta 3. Obviously the most important is the beta 1 and beta 2. Beta 3 not very much important. Beta 1, the main site or location is the heart. Positive inotropic, positive chronotropic and positive chronotropic effect, that is the increased force and rate of contraction, increased AV conduction. আর কোথায় থাকে beta 1 receptor? In the juxtaglomerular cell of the kidney. It will increase the release of renin. Increase the release of renin. এগুলো আমি বললাম না, এগুলো পরে আসবে, স্পেসিফিক অ্যাগনিস্ট অ্যান্টাগনিস্ট। ঠিক আছে? Next is the beta 2 receptor. There will be no further isoform like alpha 1 or alpha 2, alpha 1. There is A, B, D, 2 এরও আছে A, B, C, alpha 2, A, B, C. এখানে কিন্তু সেরকম কিছু নেই। এখানে beta 1, beta 2 and beta 3. Beta 2 কোথায় বেশি আছে? Mainly the smooth muscles. কোথায়? Bronchial relaxation, gastrointestinal relaxation and genitourinary relaxation. Of which the most important is this bronchial smooth muscle, most important. Another important site is the skeletal muscle. Can be important? Number 1, glycogenolysis and uptake of potassium ion. যদি uptake of potassium ion into the muscle cell হয়, তাহলে ব্লাডে কি হবে? পটাশিয়ামটা রিডিউসড। এটা কোথায় লাগবে এই অ্যাকশনটা আমাদের? যখন একটা কম্পাউন্ড ফ্র্যাকচার এলো তোমার কাছে, lacerated injury of the various muscles, shock, as well as there will be, due to laceration of the muscle, there will be release of potassium into the vessel. That will lead to alarming hyperkalemia that may stop the heart. So in this time, beta 2 agonists may be helpful to reduce the blood level of potassium. That is the important thing. And beta 2, and lastly beta 3, it is present in the adipose tissue. It will stimulate the lipase enzyme, breakdown of triglyceride. There will be increased release of the free fatty acid in the blood. Free fatty acid in the blood, that is the process is known as the lipolysis. Now coming classification of sympathomimetic agent. Classification of sympathomimetic agent. It may be divided into three. Another is the indirectly acting, and third one is the mixed acting. Directly acting means the agents or drugs which directly stimulate the different types of receptor. Those are directly acting. Indirectly acting means they have got no direct interaction with the adrenergic receptors. Then how they will act? They act indirectly by increasing the release of norepinephrine into the synaptic cleft. So that is why they are termed as indirectly acting. And third group is the mixed acting. That means the drugs will act by both these action. They have got both direct action as well as indirect action. Now let us see what are the drugs. ইনডাইরেক্টলি এখন দেখো দুরকম ভাবে হয়। একটা হচ্ছে আমি যদি এই আপটেক 1টাকে ব্লক করি, অথবা রিলিজিং ড্রাগ। এখানে আপটেক ব্লক করলে এর কনসেন্ট্রেশন বাড়বে, আর যদি রিলিজ বাড়িয়ে দিই তাহলেও এর কনসেন্ট্রেশন বাড়বে। আর এনজাইম যদি ইনহিবিট করি এখানটায় তাহলেও আমার এই কনসেন্ট্রেশন বাড়বে। সো দিজ আর দ্য থ্রি ওয়েজ বাই হুইচ উই ক্যান indirectly increase the concentration of norepinephrine at the synaptic cleft. And lastly, mixed acting has got both action, that is the direct action as well as the indirect action. এটা তোমরা আগেই বলে দিয়েছি আমি। সরি, এখানে একটা ইম্পর্টেন্ট কতগুলো আছে। ব্রঙ্কিয়াল অ্যাজমায় আমরা বিটা 2 অ্যাগনিস্ট ইউজ করি। When the physician will start beta 2 agonist for the first time in a patient suffering from chronic bronchial asthma or acute bronchial asthma, the effect will be very satisfactory. But if the patient is suffering from chronic bronchial asthma, that means they have to use this drug regularly for long. What will happen? After few months, it will be seen that the patients are no longer responsive to the beta 2 agonist. Why? There are certain terms, that is the desensitization, আর একটা হচ্ছে down regulation. Desensitization means there will be no alteration of the number of receptors. Number of receptors will not be affected by the drugs, but the availability of the receptor will be less. That's why the transmitter or the sympathomimetic, that is the transmitter, will not act or will not find any receptor to be combined. So that is the receptor desensitization. It occurs when you use certain blockers. আর down regulation কোথায়? এখানটায়, ওখানে where the number of receptors will be reduced. In beta 2 agonist, the number of receptor will be reduced so that the desired actions of beta 2 agonist or salbutamol will not be there in bronchial asthma. আর desensitizationটা কেন হয়? এই জিপিসিআর কি করে কাজ করে? জি প্রোটিন কাপল রিসেপ্টরের সঙ্গে বাইন্ড করে কাজ করে। হ্যাঁ, অনেকদিন করলে পরে কি হয়? দে উইল বি ডিফসফোরাইলেটেড, and there is one enzyme that is responsible, that is the beta arrestin. With the help of this, there will be internalization of the receptor into the cytoplasm. That means that no receptor will be available at the surface. All those gone to the deep into the cytoplasm. So number of receptors same, but they are not available at the site. So that is the receptor desensitization that may occur when long continuous use of blockers are being used. Arata ki up regulation, that means the number of receptors will be much more. Ar ki arekta hocche denervation supersensitivity. Denervation supersensitivity একটা অর্গান যার আমি নার্ভটাকে যদি কেটে দিই তাহলে দেখা যাবে সেই অর্গানটাকে যদি ডাইরেক্টলি স্টিমুলেট করি তার effect will be exaggerated. That is known as the denervation supersensitivity. That is the number of receptors will be, that is the sensitivity of the receptors will be much more and number will be much more. আর আপ রেগুলেশন কোথায় কখন হয়? আমি যদি হাই কনসেন্ট্রেশনে যদি ব্লকার ইউজ করি, হাই কনসেন্ট্রেশন যদি ব্লকার ইউজ করি তাহলে সেখানে আমার কি হয়, রিসেপ্টর তো আর অ্যাগোনিস্টিক অ্যাকশন নেই, তো তাদের নাম্বার or sensitivity will be much more. That is known as the up regulation of receptor. That means if you use beta blockers and if you withdraw the drug suddenly, then there will be exaggerated beta 1 action. So that is known as the up regulation of receptor or supersensitivity. So that these are the classifications of drugs. Number 1, directly acting, it will be selective and non-selective. Selective, the drugs are alpha 1 phenylephrine, alpha 2 clonidine, beta 1 selective dobutamine, beta 2 salbutamol. There are other drugs available. I am showing here only one. And beta 3, you need not remember this beta 3, but you can find that beta 3 there is mirabegron. So these are the directly acting selective sympathomimetic agent. Indirectly acting, non-selective directly acting agents are the much more, that is the oxymetazoline alpha non-selective agent, beta non-selective only one, that is the isoprenaline or isoproterenol. Then both alpha beta non-specific is the norepinephrine and alpha beta is the, that is the norepinephrine. So this is the directly acting sympathomimetic agent. Now coming to the indirectly acting releasing agent, amphetamine, tyramine, uptake inhibitors, tricyclic antidepressant, cocaine, MAO inhibitors, I have shown, that is the moclobamide, selagelin, all these. COMT inhibitors, that is the entacapone and tolcapone. And mixed acting, there is only one drug, that is the ephedrine. It was used at one time, an effective agent for bronchial asthma. Nowadays it is not used. Why? It is one of the example for reduced action of a drug for continued use for quick successive, repeatedly. কি বলে তাকে? একটা ড্রাগ যদি উইদিন এ ভেরি শর্ট ইন্টারভ্যাল আমরা যদি পরপর ইউজ করে যাই তাহলে দেখা যায় যে তার action will be diminished, and that phenomena is known as the tolerance. Tolerance. কি হলো বলো? হ্যাঁ, টলারেন্স কি টাইপ অফ টলারেন্স? আমরা টলারেন্স বলতে যা বুঝি সেটা এটা না, এটা একটা স্পেশাল টাইপ অফ টলারেন্স, দ্যাট ইজ নোন অ্যাজ দ্য tachyphylaxis, rapid development of tolerance when the drug is used repeatedly in a short interval, and the desired action will not be achievable by increasing the concentration of the drug. So that is known as the tachyphylaxis. So this is the classification of drugs. I am not. Now coming to the actions of adrenaline. আমরা ডিফারেন্ট ড্রাগ কী করে পাই? ওই যে সাইড চেন যেটা আছে ওখানে আমরা অ্যাডিশন অল্টারেশন করলে পরে ডিফারেন্ট টাইপস অফ অ্যাড্রেনার্জিক ড্রাগস আমরা পাই, আলফা বিটা পজিশনে ডিফারেন্ট এজেন্ট ডিফারেন্ট গ্রুপ রিপ্লেস করে আমরা different types of sympathomimetic agent পাই. Now coming to the actions of adrenaline. Number one, effect on blood pressure. Effect on blood pressure. এটা ডিফারেন্ট হয়। আমি যদি একটা কন্টিনিউয়াস লো ডোজ দিই অথবা সাবকিউটেনিয়াস ইনজেকশন দিই তাহলে কি হবে, অ্যাট ওয়ান টাইম দ্য কনসেন্ট্রেশন অফ অ্যাড্রিনালিন ইজ নট মাচ মোর, তাই তো? আমি যদি স্লো আইভি ইনফিউশন দিই অথবা যদি সাবকিউটেনিয়াস ইনজেকশন দিই তাহলে আমার কি হবে, সাবকিউটেনিয়াস দিলে কি হবে, ভাসোকনস্ট্রিকশন হবে, দেয়ার বি স্লোয়ার রেট অফ অ্যাবজর্পশন. So at one time the concentration of adrenaline is not much more. That will lead to one type of effect on blood pressure. But if we give or administer rapid IV injection, there will be another type of action. Now let us see what are the different action. Here you can see that rapid IV injection systolic blood pressure will be increased. Why there will be rise in blood pressure with adrenaline? লিখে রাখো, why there is rise in blood pressure with adrenaline. প্রথমে কি হবে, আমরা ড্রাগ দিলে পরেই তাহলে ব্লাড আগে কোথায় যায়, আগে তো হার্টে যায় না, ব্লাড ভেসেলে যায়, মানে ভাসোকনস্ট্রিকশন. ভাসোকনস্ট্রিকশন কীরকম দেখতে হয়, এই যদি বেজাল লেভেল হয় ব্লাড প্রেশারে, আমি এখানে দিলাম, এই উঠে গেল, নামলো, এই দেখো বেজাল লেভেল এখান থেকে নিচে নামলো, তারপরে উঠে এলো। এটা ইনিশিয়ালি হচ্ছে আলফা 1 এফেক্ট অন দ্য ব্লাড ভেসেল, স্ট্রং ভাসোকনস্ট্রিকশন, ইনক্রিজ পেরিফেরাল রেজিস্ট্যান্স, and there will be rise in blood pressure, followed by action on the heart, beta 1, positive inotropic, positive chronotropic effect, positive inotropic, positive chronotropic effect. But why there is fall below the baseline? Adrenaline has got alpha 1 action, alpha 2 action, beta 1 action, and beta 2 action. So usually it is followed by vasodilatation due to the effect on beta 2 receptor. And remember that beta 2 receptors are more sensitive than beta 1 receptor. Beta 2 receptors are more sensitive than beta 1 receptor. তাহলে কি হবে, যখন এখানে যখন দিচ্ছি নামলো, যখন concentration is much lower, when there is lower concentration of drug in the blood, beta 1 receptor will not be activated, only the beta 2 receptor will be activated. That will give rise to vasodilatation and fall below the baseline. তারপরে কি হলো, ড্রাগটা আরো কমে গেল, তখন there is again comes to the basal level. তার মানে there are two phase, that is one phase and that is the second phase. That's why it is termed as biphasic response of adrenaline on blood pressure. Biphasic response of adrenaline on blood pressure. Whereas in norepinephrine, what is the difference? There will be no beta 2 effect. No beta 2 effect. তার মানে কি হবে, আমার এই এফেক্টটা থাকবেই না। So there will be monophasic rise of blood pressure with norepinephrine. Explanation, there is no beta 2 action of norepinephrine. So with adrenaline there is modest rise of systolic blood pressure, but the diastolic blood pressure usually falls due to the action of beta 2 receptor. It may be raised initially, but later on it will be reduced below the baseline, comes to below to the baseline. এখন কি হবে, পালস প্রেশার কি হবে, ইনক্রিজ হবে, বাট দ্য mean arterial blood pressure will not be much raised. আমার যদি সিস্টোলিক ব্লাড প্রেশার বাড়ে, ডায়াস্টোলিক ব্লাড প্রেশার বাড়ে, তাহলে কি হবে, mean arterial blood pressure will also be increased. But here the systolic blood pressure raised, but not at that extent like norepinephrine. And secondarily, there is usually fall in the diastolic blood pressure. That means the resultant effect, that is the mean arterial blood pressure, it is a little bit of rise in blood pressure, mean arterial blood pressure. Now, what will be the effect on heart rate? আমাদের হার্ট রেট কিসের উপর ডিপেন্ড করে? বিটা 1 অ্যাকশন, পজিটিভ ক্রোনোট্রপিক এফেক্ট, পজিটিভ ক্রোনোট্রপিক এফেক্ট। এখানে কি হয়, আমাদের হার্ট রেটটা আমাদের যে আমি যদি কার্ডিয়াক সাইকেল দিয়ে দেখি, এখানে হচ্ছে ডিপোলারাইজিং কারেন্ট কোনটা, ফেজ কোনটা, ফেজ 4 depolarization. So it will increase the rate of phase 4 depolarization. It is the feature of pacemaker activity. যার জন্য there is rise in heart rate, contraction and heart rate. আর কি হয়, যখনই if there is excessive rise in blood pressure, what will happen? কি হয়? Body will try to compensate it. How? কোন রিফ্লেক্স? কি হলো, সব ভুলে গেছো? Baroreceptor reflex or stimulation comes into play. So there will be vagal stimulation. Vagal stimulation. Vagal stimulation means release of acetylcholine. It is an inhibitory ion to the heart. So there will be decrease in the heart rate. Decrease in the heart rate. So one hand with the help of beta 1 action, heart rate will be increased. But on the other hand, vagal stimulation at the height of rise in blood pressure will be decreased. আর কোথায়? Due to the action on beta 2 receptor, there is vasodilatation. Vasodilatation হলে কি হবে? ফল ইন ব্লাড প্রেশার, ডায়াস্টোলিক প্রেশার ফল করবে। তাহলে কি হবে, আমার এই যে ভেগাল স্টিমুলেশনটা ডিপেন্ড করে হোয়াট ইজ দ্য লেভেল অফ মিন আর্টারিয়াল ব্লাড প্রেশার। আমার মিন আর্টারিয়াল ব্লাড প্রেশার যদি খুব বেশি বাড়ে, তখনই কিন্তু স্ট্রং ভেগাল স্টিমুলেশন হয়। কিন্তু এখানে কি হয়, আমি যা প্রথমেই বললাম যে মিন আর্টারিয়াল ব্লাড প্রেশার নট মাচ রেজড। তার জন্য কি হবে, ভেগাল স্টিমুলেশন উইল নট বি মাচ পাওয়ারফুল। বাট অ্যাজ দেয়ার ইজ vasodilatation, that will lead to increase in the heart rate, and with the action of adrenaline, again there will be direct action on the beta 1 receptor, there will be increase in the heart rate. The resultant effect কি হলো, আমাদের বিটা 1 অ্যাকশনের জন্য হার্ট রেট বাড়লো, আর ভেসোডাইলেটেশনের জন্য আমার রিফ্লেক্স ট্যাকিকার্ডিয়া হলো। আর অন দ্য আদার হ্যান্ড মিন আর্টারিয়াল ব্লাড প্রেশারের জন্য ভেগো স্টিমুলেশন হলো নট অ্যাট দ্যাট লেভেল, কম হলো। তাহলে আমার দুটো ফ্যাক্টর হচ্ছে ইনক্রিজ ইন দ্য হার্ট রেট, দুটো ফ্যাক্টর, বিটা 1 স্টিমুলেশন অ্যান্ড রিফ্লেক্স ট্যাকিকার্ডিয়া ডিউ টু ভাসোডাইলেটেশন। আর অনলি একটা এফেক্ট ভেগাল স্টিমুলেশনের জন্য আমার একটু ব্র্যাডিকার্ডিয়া হতে পারে, বাট this will be more powerful. So with adrenaline we have got tachycardia. এটা বোঝা গেছে? With adrenaline we have got tachycardia. Now tell me, what will happen if we administer norepinephrine? তাহলে কি হবে? কি হবে? হার্ট রেট কি হবে? আমি মেকানিজম বলে দিলাম। নন এপিনেফ্রিনে কি আছে, ডিফারেন্সটা কি? ইট হ্যাজ গট নো বিটা 2 অ্যাকশন। আর এর কি, সিস্টোলিক প্রেশার মাচ রেজড, ডায়াস্টোলিক প্রেশার উইল অলসো বি রেজড। তাহলে কি হবে, মিন আর্টারিয়াল ব্লাড প্রেশার উইল বি রেজড মোর দ্যান দ্য অ্যাড্রিনালিন। এখানে কি কোনো ভাসোডাইলেশন নেই, তাহলে আমার নো রাইজ ইন হার্ট রেট, the factor will not be prominent here, rise in heart rate, only the beta 1 action. কিন্তু তার এগেনস্টে আমাদের কি আছে? স্ট্রং ভেগো স্টিমুলেশন, রিফ্লেক্স ট্যাকিকার্ডিয়া নেই। তাহলে এখানে কি হবে? আমার ব্র্যাডিকার্ডিয়া উইল বি প্রমিনেন্ট হিয়ার, বোঝা গেছে না বোঝা যায়নি? কি হলো? এখানে বিটা 1 এফেক্টের জন্য পজিটিভ টোনোট্রপিক এফেক্ট হচ্ছে, হার্ট রেট বাড়লো, কিন্তু at the height of rise in blood pressure, strong vagal stimulation that will give rise to the bradycardia. এফেক্টের চেয়েও টোনোট্রপিক এফেক্টের চেয়েও বেশি হয় এটা, যার জন্য আমার ব্র্যাডিকার্ডিয়া হলো। আমার কিন্তু বাকি দুটো নেই, কিন্তু রিফ্লেক্স ট্যাকিকার্ডিয়া হচ্ছে না আমার। আর মিন আর্টেরিয়াল ব্লাড প্রেশারটা উপরে বাড়ার জন্য ভেগাল স্টিমুলেশন আরও বেশি হচ্ছে, তাহলে আমার হার্ট রেটটা কমলো এখানটায়। বোঝা গেছে? ইজ ইট ক্লিয়ার? এফেক্ট অফ ভেরি স্মল ডোজ অফ নরএপিনেফ্রিন। এবার তোমাদের জ্ঞান থেকে বলো তো একটু, যা শুনলে এখন পর্যন্ত, হোয়াট উইল বি দ্য এফেক্ট অফ অ্যাডমিনিস্ট্রেশন অফ ভেরি স্মল ডোজ অফ এপিনেফ্রিন? নিশ্চয়ই কোনো কারণ আছে। কি এফেক্ট পাবো আমার ব্লাড প্রেশারের উপরে? ভেরি স্মল ডোজ, বলো। হ্যাঁ বলো, কি বলো? স্লাইটলি রাইজ হবে। আর কেউ কিছু বলবে? কি বলবে না? আমি কি বললাম? বিটা 2 রিসেপ্টার্স আর মোর সেন্সিটিভ দ্যান বিটা 1 রিসেপ্টার অ্যান্ড আলফা রিসেপ্টার। ভেরি স্মল ডোজ মানে কি? এই যে ফল বিলো দ্য বেসলাইন হলো, কি কেন হলো? যেহেতু কনসেন্ট্রেশন ইন দ্য ব্লাড কমে গেল। আর আমি কি বললাম? বিটা 2 রিসেপ্টার্স আর মোর সেন্সিটিভ দ্যান দ্য আদার রিসেপ্টার। তার মানে যদি কম ডোজ কনসেন্ট্রেশন থাকে, তখন কি হবে? বিটা 2 রিসেপ্টার্স উইল বি স্টিমুলেটেড অনলি। তা বিটা 2 রিসেপ্টার স্টিমুলেটেড হলে কি হবে? এটা কোথায় আছে? ইট উইল কজ ভাসোডাইলেশন অফ দ্য ব্লাড ভেসেল সাপ্লাইং দ্য স্কেলিটাল মাসল। তাহলে কি হবে? অনলি দ্যাট ইজ সেকেন্ড ফেজ। বাইফেজিক বললাম না? বাইফেজিকের ইনিশিয়াল ফেজ হচ্ছে রাইজ ইন ব্লাড প্রেশার, অ্যান্ড দ্য সেকেন্ড ফেজ ইজ দ্য ফল বিলো দ্য বেসলাইন। হিয়ার উইল only get the single phase, that is the fall of blood pressure. So that is the importance of knowing this very small, what is the effect of very small dose of adrenaline. Slow inhibition and you can see here systolic pressure moderately rise, diastolic pressure very small concentration falls, and mean arterial blood pressure not much raised. Heart rate will be increased. Heart rate will be increased here. Now here you can see in this picture it will be more clear to you. You can see that is the coming to the peripheral resistance. Peripheral resistance is the determinant of alpha 1 stimulation. Vasoconstriction increase the peripheral resistance. Alpha 1 receptor, that is the norepinephrine, is a powerful vasoconstrictor. So there will be usually much raised peripheral resistance. With adrenaline, as we have told, that there will be vasodilation that will lead to decrease vasoconstriction. And with isoprenaline has got no effect on alpha receptor. তার মানে কি হবে? এর vasodilation will be much more than the other two compound. Now coming to the blood pressure, with non-epinephrine you can see that systolic pressure rise is much more. Diastolic pressure will also be raised here. So the mean arterial blood pressure, significant change in mean arterial blood pressure in the form of rise. Whereas in case of adrenaline you can see that systolic pressure is not much raised like that of norepinephrine. Diastolic pressure usually falls, so the mean arterial blood pressure only slight rise. That's why we are getting tachycardia with epinephrine and bradycardia with norepinephrine. You can see that heart rate is reduced here, norepinephrine, and here it is increased. That is the reason. And here, obviously, there will be excessive tachycardia due to strong beta 1 effect and with the beta 2 effect, strong vasodilation and reflex tachycardia. Ever clear hoyeche? Now coming to the on vascular system. আচ্ছা তার আগে আমি বলি হার্টের উপর হার্টে কি হয় পজিটিভ আইনোট্রপিক এফেক্ট তার মানে systolic contraction will be much more but the diastole somewhat reduced systolic the duration will be shorter and contraction will be much more but the diastole usually prolonged আর তাহলে কি হবে can I give adrenaline in heart failure অ্যাড্রিনালিন কিন্তু কার্ডিয়াক আউটপুটও বাড়বে তার কারণ কি পেরিফেরাল রেজিস্ট্যান্স কম থাকে আমার কন্ট্রাকশন বাড়ছে কিন্তু পেরিফেরাল রেজিস্ট্যান্স দ্যাট ইজ দ্য আউটফ্লো রেজিস্ট্যান্স ইজ মাচ লেস সো কার্ডিয়াক আউটপুট উইল বি ইনক্রিজড বাট নন এপিনেফ্রিনে কিন্তু কার্ডিয়াক আউটপুট কিন্তু কমে যায় বিকজ অফ স্ট্রং ভাসোকনস্ট্রিকশন তাহলে কি আমরা ক্যান উই ইউজ অ্যাড্রিনালিন অর এপিনেফ্রিন ইন কেস অফ হার্ট ফেলিওর কি হার্ট উইল নট বি এবল টু পাম্প এফিসিয়েন্টলি এপিনেফ্রিন cause positive inotropic agent that is the increased systolic contraction. Can you use epinephrine in heart failure? No. Why? Because of any contraction there is increased consumption of oxygen. Oxygen demand will be increased and oxygen consumption will also be increased and that will aggravate the heart failure. That's why we will not be able to use adrenaline in congestive heart failure for the treatment of heart failure. Here on the vascular system depend on the type of receptors involved and the organ supplied. Alpha receptor decreased blood flow due to vasoconstriction. কোথায় হয় mainly skin, mucous membrane and renal where the precapillary resistance vessels are mainly affected. Also the large vessel and the venules also be constricted by the action of adrenaline on alpha 1 receptor. Beta 2 receptor কি হবে vasodilation due to the blood vessels supplying the skeletal muscle. So vasodilation and also in the liver and coronary blood vessel. So in certain part there will be decreased supply of which main is the skin, the peripheral structure, skin and mucous membrane and the kidney, whereas in the muscle the blood supply will be much more. Cerebral blood vessel will not be affected. কেন? Because আমরা যদি adrenaline দিই it has to cross the blood-brain barrier but it cannot penetrate the blood-brain barrier. So any effect or change in the cerebral blood flow, it is due to the effect on the vascular system which secondarily may alter the cerebral blood vessel. It may be increased or slightly decreased. On heart you can see that decrease rate and cardiac output decrease হবে না cardiac output is maintained with adrenaline but cardiac efficiency will be decreased এখানে শুধু ওই সিওটা বাদ দিয়ে দাও increase force of contraction and decrease ওটা অ্যারোটা উপরে উঠে গেছে decrease cardiac efficiency So increase force of contraction, increase heart rate and increase cardiac output but decrease the cardiac efficiency. অ্যারোটা নিচে নেমে গেছে উপরে উঠে গেছে একটু ঠিক আছে এগুলো সেম জিনিস দেখা আছে দেখো হার্ট রেটে কি হবে কার্ডিয়াক আউটপুট কিন্তু আমি যা বললাম দেখো এপিনেফ্রিনে কিন্তু বাড়ে বাট ইন কেস অফ নন এপিনেফ্রিন ইউজুয়ালি রিডিউসড অ্যারিথমিয়া দুটোতেই বাড়ে কিন্তু অ্যাড্রেনালিন দিলেও there will be tachycardia and There may be arrhythmia with norepinephrine, there may also be associated with arrhythmia. Coronary blood flow will usually increase, blood pressure বলেছি, mean arterial blood pressure বলা হয়ে গেছে। Peripheral resistance, total peripheral resistance with epinephrine decrease and norepinephrine much increased, coronary blood flow maintained, cerebral blood flow not usually altered by the direct action of the either adrenaline or norepinephrine on the receptor because they have got less entry to the cerebral or the brain. Metabolic effect, oxygen consumption increased, blood glucose level will be increased. আমরা বলছি পরে metabolic effect কি হয়। The effect on smooth muscle, of which the most important effect is on the beta 2 receptor present in the bronchial muscle. কি হবে তার জন্য? Bronchodilation, decreased release of the mediators in case of bronchial asthma. তার মানে লিকোট্রিয়েন্স, হিস্টামিন অতটা না, লিকোট্রিয়েন্স গুলো less released by the mast cell. So there will be beneficial effect in bronchial asthma. Beta 2 receptors mediated dilatation in bronchial and gastrointestinal smooth muscle. আমাদের clinically most important হচ্ছে bronchial smooth muscle. Next হচ্ছে uterine smooth muscle. It will depend the phase of the cycle, whether pregnant or non-pregnant, and whether the early pregnancy or late pregnancy. That will depend. That will interfere with the sensitivity of the uterine smooth muscle to the adrenaline. As for example, in the terminal phase of the pregnant uterus, it will be relaxed due to the beta 2 effect. But আগে কি হবে? Due to alpha effect, there will be contraction of the uterus. So এগুলোর উপর ডিপেন্ড করবে। নেক্সট হচ্ছে urinary bladder, এটা আমরা কিছুটা তো বলেই দিয়েছি। Detrusal muscle will be relaxed due to beta receptor stimulation. Trigone and sphincter will be contract due to alpha 1 receptor stimulation. Alpha 1 receptor stimulation. আর কি CNS এ আমি যে বললাম তোমাদের, ইউজুয়ালি এই যে রেস্টলেসনেস, অ্যাপ্রিহেনশন, হেডেক, এগুলো দিজ আর দ্য সিকুয়েলি অফ দ্য আদার চেঞ্জেস ইন দ্য বডি, not due to the direct effect of norepinephrine or epinephrine in the CNS. Most important is the metabolic effect, blood glucose level increased. So in diabetic patient, we should not prescribe epinephrine usually. Why? Because they can further raise the blood glucose level. Blood glucose level কিভাবে বাড়বে? Number 1, যদি আমার ইনসুলিন সিক্রিশন কমে যায়, Number 2, যদি ইনক্রিজ প্রোডাকশন অফ গ্লুকোজ হয়, দ্যাট ইজ নোন অ্যাজ দ্য নিওগ্লুকোজেনেসিস। আরেকটা কি? গ্লাইকোজেনোলাইসিস। যদি গ্লাইকোজেন ব্রেকডাউন হয়, আরেকটা কি হরমোন যদি বেড়ে যায়? গ্লুকাগন। এখানে কি হয়? গ্লাইকোজেনোলাইসিস অ্যান্ড নিওগ্লুকোজেনেসিস। আমরা দেখেছি আলফা অ্যাকশন অ্যান্ড অলসো বিটা অ্যাকশন also plays some main role in the process of glycogenesis and neoglucogenesis. Insulin level, it will be reduced due to the action of alpha receptor, alpha stimulation, alpha 2 receptor stimulation. And by stimulation of beta receptor, there will be increased glucagon secretion. So by this way, it can increase the blood glucose level. Very, very important. Another is the increase the free fatty acid and lactate level. As I told you, it is due to the increased breakdown of triglyceride by the increased lipase concentration, and that is done by beta 3 receptor present in the adipocyte. So these are the main actions of adrenaline, and apart from this, some other actions are there. Those are the main actions. That is on eye. On eye, it will decrease the production of the aqueous humor, and it is due to the action on the alpha 1 stimulation. It will cause vasoconstriction and thereby decrease the formation of aqueous humor. তাহলে এটা কোথায় কাজে লাগবে? গ্লকোমা, ফর দ্য ম্যানেজমেন্ট অফ গ্লকোমা। বাট এখানে কোশ্চেন আছে, গ্লকোমা ট্রিটমেন্টের জন্য কি আমি সাবকিউটেনিয়াস অ্যাড্রেনালিন দেবো? তাহলে তো আমার আদার সিস্টেমের ট্যাকিকার্ডিয়া, রাইজ ইন ব্লাড প্রেশার, আরও অনেক কিছু হবে। তাহলে আর একটা কি আছে, আমার লোকাল ইনস্টিলেশন কাজ করবে? If you use adrenaline locally, that is on the conjunctiva in the form of eye drop, does it affect the aqueous humor formation? কি মনে হয় তোমাদের? এটা তোমাদের একটু কমন সেন্স অ্যাপ্লাই করতে হবে। আমি যে কোশ্চেনের থ্রো থেকে চিন্তা করতে হবে যে কোন এক্সামিনার ইউজুয়ালি কোশ্চেনের থেকেই বলে দেয় যে অনেক সময় যে অ্যান্সারটা কী হবে। আমি যখন বলছি যে এখানে দেওয়া যাবে না, এখানে তাহলে কি দেওয়া যাবে, তার মানে দেওয়া যাবে না। কেন দেওয়া যাবে না? ইট ক্যানট পেনিট্রেট, it cannot go to the site. But there is one drug, timolol to beta blocker, dipivefrin. It will be converted into the adrenaline after gain access at the site of action. So it can cause mydriasis, but for mydriasis adrenaline is never used. Only for in chronic simple glaucoma we can use dipivefrin, a prodrug of adrenaline that can be used. Plasma potassium, এটা আমি আগেই বলেছি, what is the clinical significance? In compound fracture, laceration of muscle, there will be increased level of blood potassium level that can be minimized by use of beta-2 agonist. Skeletal muscle, there will be, you can see that if you use beta-2 agonist, যারা সালবুটামল এগুলো নেয় তাদের দেখবে যে কিছুদিন পরে হাত এরকম বলো কাঁপবে। এটা কি হয়? Facilitation of skeletal muscle contraction, not due to the other receptor, but due to the action on beta-2 receptor present in the skeletal muscle, facilitation of the neuromuscular transmission that will lead to contraction and tremor. Pharmacokinetic, it is not absorbed. Because they are catecholamine. They are metabolized in the liver. It is unstable in alkaline solution. It is used either usually subcutaneously or intramuscularly. Rarely it can be given through intravenous route. Usually subcutaneous and intramuscular, the concentration is 1 milligram per ml, that is a 1 in 1,000. 1 in 1,000. It can be available in combination with local anesthetic to prolong the action of local anesthetic. That adrenaline can be combined. So in that the concentration is much lower. In IV it will be 1:10,000 solution it can be given. Usual dose is the 0.3 to 0.5 milligram IM or subcutaneously. মনে রাখতে হবে, 0.3 to 0.5 milligram subcutaneous or IM, and the concentration is 1:1000. এই তিনটে জিনিস মনে রাখতে হবে।
EC stands for endothelial cell, or the cells that lines the vesicle, the intimal layer, okay? And next is cytokines, very important, a diverse group of family of cytokines that comes from macrophages, lymphocyte, endothelial cells and mast cells. And neuropeptides, they also come from the leukocytes. So these coming from histamine and ending with neuropeptides, these are all the mediators that are self-derived mediator, okay? And the rest is plasma protein derived mediator, okay? And among that plasma protein derived mediator, two are the complement system and the kinin system, okay? So the complement system and the kinin system, their major source of secretion or production is liver, our metabolic factory, the powerhouse, okay? From complement activation, the important mediators are C3A, C5A, C3B, C5B29. These A denotes for activated, okay? So C3A, this is the active form. C5A, this is the active form of C5, and C3B, this is the inactive form. So C3 and C5A, these are also called anaphylatoxin, okay? Anaphylatoxin are the chemical mediators which initiates and which facilitates the membrane attack complex C5B to C9. They all together collectively form a membrane attack complex, like a very strong weapon, Kalashnikov, okay? So membrane attack complex, anaphylatoxin, C3 to C5A, alternative pathway, classical pathway, lectin pathway, the whole process of complement activation and action, it will be taught in detail in the subject of microbiology. And the kinin system, composed of fibrinolytic system, okay? Kinin system, bradykinin, the important part, and the kinin system, it helps in coagulation and anticoagulation, okay? coagulation and fibrinolysis system. So now the mediators and their actions. So whenever you have been taught the basic concept of acute inflammation, you know the landmark point of inflammation is vasodilatation and increased vascular permeability. So no process of inflammation won't occur if there is not vasodilatation and increased vascular permeability in the system. So vasodilatation and increasing vascular permeability are the chief functions of any mediators you know, and you will learn in the chapter of acute inflammation. Okay, if you don't know or you don't memorize the whole exhaustive list, just don't forget that any mediators won't have any action except vasodilatation and increased vascular permeability. So these two things, vasodilatation and increased vascular permeability, increasing vascular permeability, are invariably functions of the mediators of acute inflammation. এই এত দেরি করে কেন তোরা? ও ঠিক আছে, পিছনে বস তোরা দাদা, কোনো ব্যাপার নয়। So chief vasodilators in our body: prostaglandins, nitric oxide and histamines. So from the previous list of cell-derived mediators of acute inflammation, the most competent vasodilators in that list are categorized for the vasodilatation list over here, that are prostaglandins, nitric oxide and histamine. So these three mediators are chief vasodilators. Okay, don't forget. Next is increased vascular permeability, the next important action of the mediators of acute inflammation. So the chief responsible cells or mediators are histamine, serotonin, C3A and C5A, collectively known as anaphylatoxin, bradykinin, leukotrans, leukotrans C4, leukotrans D4, leukotrans E4. So leukotrans are the member of the family of icosanoids. Okay, next is platelet activating factor and next is substance P. So this list is categorized to show you the which chemical mediators have exact and intrinsic ability for the maximum vasodilatation of the affected tissue part. Next action is leukocyte recruitment and activation. The mediators are TNF and IL-1. These are all chemokines, okay, cytokines, tumor necrosis factors and interleukin-1. Next is chemokine, also complement leukotriene B4. So this group of chemical mediators, they have maximum propensity to recruitment of the leukocyte and activation of the leukocyte to the site of inflammation. So leukocyte is the bactericidal thing. So leukocyte is the protective thing that comes to the place of inflammation to protect our body, our tissue homeostasis against the culprit pathogen. Okay. Next is fever, substance P, prostaglandin, interleukin-1. So fever is mediated by interleukin-1 and tumor necrosis factor. Pain, chief responsible chemical mediator is prostaglandin, bradykinin, but the chief mediators of pain is prostaglandin. So whenever you have pain in your body, we prescribe, the doctors prescribe the NSAID, non-steroidal anti-inflammatory drug. So this drug, this group of drug, they inhibit the formation of prostaglandin and substance P. So the pain sensation will be lessened. So pain is mediated by prostaglandin. Okay, and tissue damage, the last function of the mediators, these are the functions of lysosomal enzymes of leukocyte, reactive oxygen species and nitric oxide. So tissue damage, mainly attributed by the action of reactive oxygen species. এটা কি হচ্ছে বারবার ব্যাটারি কমে গেছে কি দাবি এটা okay so leukocyte enzyme or neutrophilic enzymes neutrophil has granules neutrophil has two types of granules primary granules secondary granules in those granules there are various bactericidal enzymes like protease like cathepsin G like myeloperoxidase so all the bactericidal enzymes those are stored in the granules of neutrophil cytoplasm of neutrophil so whenever there is necessity of tissue damage due to inflammation those enzymes from leukocyte and lysosome will come to the place okay next so this is the chart of total mediators of acute inflammation this is cell derived mediator the list and the next one is plasma derived mediator it comprises of complement system coagulation and chidin system now coming with the first the most ancient discovered one histamine okay histamine where it comes from basophil okay mast cell basophil they have granules and they have IgE attached to their surface okay IgE or immunoglobulin E is the chief immunoglobulin or chief antibody to combat against the allergic reactions okay whenever they are in any allergic reaction or atopy situation in our body the most pivotal role played by immunoglobulin E okay so this immunoglobulin E whenever antigen binds to the antigenic binding site of immunoglobulin E then the degranulation occurs from the cells okay so these are the granules mast cell or basophil so whenever any allergic inflammation or allergic antigen exposure occurs these granules will be detached from the cytoplasm and the allergic reaction or inflammatory reaction occurs next is cytokines in cytokines we have to read or know about interleukin tumor necrosis factor and chemokines and interleukin has a list like Kodavas 100টা interleukin আছে coming from interleukin 1 interleukin 2 interleukin 3 and the list goes on okay but the most important is interleukin 1 next important is interleukin 6 okay now these are also cytokines interferon alpha interferon beta and interferon gamma among these interferons the most important or most predominant action has interferon gamma okay so interleukins they also secretion by individual cells and signal peptide and signal protein activation and interleukin has multiple spectrum of action okay like immune system hematopoietic system non-specific defense okay so now we have to read about the immune system mechanisms of the cytokines like interleukin and interferon and tumor necrosis factor and this type of interleukin like GCSF or granulocyte colony forming unit GMCSF granulocyte macrophage colony forming unit this function is confined to the hematopoiesis or the production of blood cells of various lineages in the bone marrow okay so the functions of interleukin or functions of cytokines in acute inflammation we need to know the effects are mainly categorized into 3 to 4 things okay by bacterial product immune complex toxin physical injury and other cytokines exposure activation of macrophage so activation of macrophage is very important it may be comes from other cell like leukocytes but activation of macrophage, and in the inflammation, it has the chief role for production of interleukins. Okay, so the interleukins and tumor necrosis factor, it has wide spectrum of roles. It has endothelial effects, it has systemic effects, it has fibroblast effect and leukocytes effect. Okay, among all these 4 effects, the most important one are endothelial effects and systemic effects. What are the endothelial effects? It increases the leukocyte adherence. So in the site of inflammation, the increased stickiness of leukocytes or white blood cell or neutrophils, the increased stickiness of the outer cell surface of the leukocyte, that facilitates the attachment of the leukocyte or the neutrophil to the endothelial surface of the vessel, and the cell rolls along the endothelial surface and it leaks out from the gap between the 2 endothelial cells, and the cells then comes to the extracellular space by the mechanism of diapedesis, and at the site of tissue injury, it releases the bactericidal enzymes from their granules and takes action in antimicrobicidal or antibactericidal effect. Okay, so leukocyte adherence is most important. Endothelial effect, the interleukins, it increases the leukocyte adherence, increases the prostacyclin synthesis or PGI2 synthesis. Okay, so this is one of the icosanoids. So increase the production of prostacyclin synthesis. Now another important endothelial effect is increase in procoagulant activity and decrease in anticoagulant activity. So increase in procoagulant activity and decrease in anticoagulant activity, what does it mean? The system or the blood in the vessel tends to more clot than flow. Increase coagulant activity and decrease anticoagulant activity. It means that the blood cells or the flowing blood is very vulnerable to clot at any time. So it results from the vascular stasis, and due to increased clot formation, the cell of the clot formation like platelets, like fibrinogen meshwork, they all come together to the place of clot, and it helps in the control of the pathogen to a same localized site. Okay, concept clear? So increase procoagulant activity and decrease anticoagulant activity, and it also increases the interleukin 1, interleukin 8, interleukin 6 and PDGF secretion, platelet derived growth factor secretion. So I told you earlier, there's all the interleukins and the chemokines, they are like chain reaction. One chemical mediator releasing from one cell, it triggers thousands of chemical mediators to be released from other various cells in adjacent tissue or adjoining part to the site of inflammation. Okay, concept clear? It's like a chain reaction. Okay, now coming to the systemic effect, main is fever. So interleukins are interleukin 1, interleukin 6 has intrinsic activity as pyrogen, so it induces fever. Now increase sleep and decrease appetite. Decrease appetite, জ্বর হলে খেতে ইচ্ছা করে না কারোরই, তাহলে decrease appetite, and this decreasing appetite or anorexia is attributed by the function of TNF, tumor necrosis factor. Okay, this interleukin is attributed to the activity of কি হলো এটা বারবার এরকম হচ্ছে কেন? চকফক দিয়ে পড়াবো নাকি? So tumor necrosis factor coming from to the fibroblastic effect, increased proliferation of the fibroblast. Fibroblasts are essential to limit the inflammation. Whenever you will be taught in chronic inflammation, you will be taught that the chronic inflammation, the process of healing, fibroblast has an immense role to localize and to heal the tissue, localize the inflammation and heal the tissue. Okay. So increase collagen synthesis, increase collagenase, increase protease activity, and increase prostaglandin E synthesis. Okay. So these are the functions of interleukins. So the broad function is endothelial effect, next is systemic effect, next is fibroblastic effect, and leukocyte effect like increased cytokine secretions. Now interleukin 1 and TNF tumor necrosis factor, nuclear solitarius of medulla oblongata. Okay, this is the pain pathway. Okay, from your knowledge of physiology. So this way interleukin 1 and tumor necrosis factor, they are increasing the temperature of the body, sorry, the temperature. Okay, this is what is called margination, adhesion, propagation, rolling, and diapedesis. So chemokine, this is the leukocyte neutrophil, this is the ligand of the outer surface of the neutrophil, and this is the chemokine secreted from the active leukocyte, and by the action of collagenase, it makes a gap through the endothelial cells that comes to the site of inflammation. So all the chemokines, they are the property of the leukocyte. They comes to the extracellular space through the gap of endothelial cells. Okay, and then they dissolve extracellular matrix by the action of collagenase, by the action of protease to distribute the chemokines to the extracellular space. Now integrin is a high affinity state, integrin ligand ICAM1. So you can say how the leukocyte is adhere to the endothelial surface when the process of inflammation starts. Okay, this is ligand ICAM, integrin ligand. Okay, integrin, selectin, p-selectin, these are all ligands. You will be taught in detail in later classes. Now coming from the icosanoids, very important, icosanoids also come as a form of short note. Icosanoids, why they are called as icosanoids? Because icosanoic acid in Greek, icosa. So icosa, this term means in Greek word 20. So icosanoic acid means 20 carbon acid. Okay, so all the molecules that comes from the arachidonic acid, that is a 20 C or 20 carbon molecule. So icosanoids, these are the molecules that come from the arachidonic acid. So arachidonic acid metabolites are collectively known as icosanoids. Okay, and icosanoids have two broad hand or two group of molecules. One is cyclooxygenase pathway, another is lipooxygenase pathway. So this is cell membrane phospholipid. You know the bilayer structure, lipid, protein, lipid, protein. Okay, lipid bilayer structure. By the action of phospholipase from the cell membrane phospholipid, the lipid bilayer structure, there is formation of arachidonic acid. Okay, so this arachidonic acid, by the action of two chief enzymes, by the action of two enzymes, that is cyclooxygenase and lipooxygenase. Okay, these are the two enzymes that splits the arachidonic acid into essential pathways and to liberate essential chemical mediators that have varieties of action and varieties of cellular distribution. Now the COX pathway or cyclooxygenase pathway. From arachidonic acid, by the action of cyclooxygenase, prostaglandin G2, the precursor molecule first forms. From prostaglandin G2, another precursor molecule, prostaglandin H2, forms. And from prostaglandin H2, two to three types of prostaglandins are formed. Another is prostacyclin or PGI2. Next is prostaglandin, that is PG2 and PGE2, PGD2 and PGE2. And another group of molecule is due to action of cyclooxygenase in arachidonic acid, the three types of molecules occur. These are prostacyclin, prostaglandins and thromboxane. And this prostaglandin and thromboxane has antagonistic action. Okay, prostacyclin, it causes vasodilatation, but thromboxane A2, it causes vasoconstriction. Okay, prostacyclin I2, it causes the inhibit platelet aggregation, but thromboxane A2 is a procoagulant, or it induces the many platelets to stick together and forms a clot. So prostaglandin, prostacyclin has just antagonistic effect than that of thromboxane A2. So this is like a balance, a chemical balance in the body. Whenever it occurs to slow the blood to make a clot, then thromboxane A2 will rule over than prostacyclin, and whenever the body demands, the tissue demands, the more vasodilatation than vasoconstriction, then prostaglandin will rule over than over thromboxane A2. So this is type of balance. And another another group কি যেটা লাইপোক্সিজেনেস পাথওয়ে থেকে আসে, একটা arachidonic acid has two main enzymatic digestion through two different pathways. From cyclooxygenase enzyme action, the chief molecules are prostacyclin, prostaglandin and thromboxane A2. And by the action of lipoxygenase, the chief molecules are leukotrienes. Okay, the types of leukotrienes are leukotrienes C4, leukotrienes D4, leukotrienes B4. So leukotrienes, what are their effects of leukotrienes? Leukotrienes have intrinsic ability to cause constriction of or contraction of smooth muscles of our bronchial tree. So whenever there will be a acute asthma attack, whenever there will be attack of acute asthma or acute bronchial asthma, there will be the most predominant chemical mediators of inflammation will be leukotrienes. Leukotriene B4, leukotriene C4, leukotriene D4. So these leukotrienes has intrinsic ability to constrict the vascular smooth muscle and cause bronchospasm. So the nebulizer always contain material or therapies that action against the leukotrienes, like Montelukast. Okay, leukotriene against the leukotriene. কি বলছিস বল জোরে, ঠিকই বলেছে, leukotriene. So leukotriene action, vasoconstriction, bronchospasm, increased vascular permeability. And lipoxin A2 and lipoxin B4, they inhibit the neutrophil adhesion and chemotaxis. So I told you earlier, these lipoxygenase pathway and the cyclooxygenase pathway enzymatic digestion leads to few molecules that have antagonistic effect. One facilitates the platelet aggregation, one facilitates the vasoconstriction, another group of molecules that inhibit the platelet aggregation and inhibit the vasoconstriction. They are vasodilators. Okay, so icosanoids, very important, can be also come as a short note apart from the long question of mediators of acute inflammation. Next is reactive oxygen species. Okay, reactive oxygen species, the free radicals of our body, that is superoxide hydroxyl radical. Okay, so superoxide in oxygen, after donating electron, it occurs as superoxide donating another electron. It comes to hydrogen peroxide. So there are free radicals in our body, namely oxygen superoxide, hydroxyl radical, this hydrogen peroxide, okay, and our anti-scavenger system of our body, that is the antioxidant system, okay. Scavenger system or antioxidant system of our body, it comprises of three enzymes, namely superoxide dismutase, catalase, and glutathione peroxidase, okay. So superoxide dismutase, catalase, and glutathione peroxidase, these three enzymes are able to convert the free radicals to convert into water and nascent oxygen, okay. So free radicals, the body, it also contains free radicals, the oxygen superoxide ion, the hydroxyl radical, and conversely, our body also has the enzymes like superoxide dismutase, glutathione peroxidase, catalase. So all the mediators, they have molecules or interchanging system of balancing, mutual balance, or some molecules they action more when their demands more, some molecules they rule over another molecules when the tissue homeostasis demands them more. So these are the reactive oxygen species, and the enzymes of neutralizing the reactive oxygen species is called the scavenger mechanism of our body. It neutralizes the free radicals injury, okay. So this is also important topic in a short note. Now nitric oxide, I told you earlier, the most potent vasodilator, okay. Vasodilator of our body apart from prostaglandin is nitric oxide, okay. So nitric oxide comes from macrophage, nitric oxide comes from endothelial cells, okay. So its action is vasodilatation. This is a complex pathway. Nitric oxide as a transmitter substance. No need to overburden you. Leukocytic lysosomal enzyme. I told you earlier. Dekho, chobi dekho, maja pabe. This is neutrophil, okay? 3 to 5 lobe neutrophil. This is granules, and this is electron microscopic picture. This is a light microscopic picture. Okay? Egulo red blood cell, RBC, egulo RBC, biconcave without nucleus. But this is neutrophil, okay? Leukocyte, lobe, nuclear lobe, 3 to 5 lobes. It has 4 lobes, and these are granules, okay? This is granules, but these granules are very inconspicuous to see under the simple microscope or light microscope. But whenever you would get an opportunity to see it under electron microscope, these are the granules. The larger ones are primary granules, and the smaller are the secondary granules, okay? So what are the granules? What are the enzymes stored within that? And what are their function? The crucial function, okay? Neutrophil elastase, cathepsin G, protease 3, myeloperoxidase. I told you during the start of the class, that is acidophilic or primary granules. These are the enzymes. It has a role in bactericidal or killing the bacteria by the process of phagocytosis, okay? Cell killing. Specific and tertiary granules, lactoferrin, lysozyme, lipocalin, and MMP6. All other the granules have contains the other enzymes, okay? So this is leukocytic lysosomal enzymes kills the culprit pathogen by the action of these enzymes and the action of phagocytosis, okay? NETs or neutrophil extracellular trap. NET is not also national eligibility test. It is also known as NET, neutrophil extracellular trap. So with the help of these granules, these neutrophils, they forms a meshwork like structure around it, and it engulfs and it attacks or attach the bacteria in its periphery in that trap or in that meshwork and eventually kills it by secreting the bactericidal enzymes. Concept here, NETS or neutrophil extracellular trap. Another neuropeptide platelet activating factor, substance P. It is involved in pain pathway, dorsal root ganglia. Okay, pain pathway of our body. So, bradykinin, prostaglandin, serotonin, histamine, all ATP also. Okay, these all increases the production of substance P that involves in pain pathway or pain sensation. Now coming to the plasma protein derived mediators, I told you earlier, these will be taught in your microbiology lecture. Complement system, just you show the classical pathway and the alternative pathway. Another pathway is there that is also called lectin pathway. Okay, but you just remember there is two mode of activation mainly. One is classical pathway and another is alternative pathway. Whatever may be the initiation, whatever may be their pathway of activation, whether it is classical pathway or the alternative pathway, all the pathways they converge to a single common pathway to make a strong weapon like membrane attack complex, and this membrane attack complex is composed of C5b to C9, C5b, C6, C7, C8 and C9. So these 4 to 5 complement, they collectively forms a membrane attack complex and kills the bacteria. Okay, but apart from the killing bacteria, it also has functions in our inflammation in the form of C3a, C5a, C4a, anaphylatoxin, and these are also have similar effects of vasodilatation, increased vascular permeability, chemotaxis, degranulation of basophil, contraction of smooth muscles. Okay, and C5a has the maximum and the strongest of all. Okay, so C5a has the maximum action of contraction of smooth muscle, increases the vascular permeability, degranulation of basophil. For this property, it is also called as anaphylatoxin. So it invites the anaphylaxis reaction. It facilitates the anaphylaxis reaction. Okay, and also it has role in chemotaxis and release of free O2 radical or reactive oxygen species and lysosomal enzymes. So I told you earlier, these things are like chain reaction. One molecule, it involves other molecules. Hey, please do come to our party. Okay. Now, antimicrobicidal effect, complement system. This is membrane attack complex. So, coagulation and kinin system, I told you. The fibrinolytic system, it fibrinolytic and coagulation and kinin system. These are all the system. It is also have property of balancing together a balance. Coagulation, when the body needs to clot the blood, then coagulation system, the procoagulant activity will rise. When the body demand the blood to flow, then the anticoagulant activity or fibrinolytic activity will predominate. So coagulation system and kinin system, okay, the extrinsic pathway, the intrinsic pathway, the common pathway, okay, all this pathway will be taught in pathology, okay, in the chapter of coagulation or in the part of your hematology portion. So thank you all.